Welcome back to Breastfeeding Nurtured with the tagline The First Step to Lifelong Health. In session 12, Breastfeeding How to Increase, Sustain, and Re-lactate, we explored one of the most common concerns faced by mothers, that is, how to build up milk supply, maintain it over time, and restore breastfeeding when it has been interrupted. Today, we move to session 13, Breastfeeding Approach in Special Situations. In this session, we will focus on common maternal medical conditions that often raise concerns about breastfeeding. Many mothers are advised to stop breastfeeding unnecessarily because of these conditions. However, current evidence shows that with appropriate treatment and a few simple precautions, breastfeeding can usually continue safely. Now, the aim of this session is to help healthcare professionals provide clear evidence-based guidelines so that mothers receive the right advice and are supported to continue breastfeeding whenever possible. Before we begin, don't forget to subscribe to my channel by simply scanning the QR code to stay updated with the latest evidence-based breastfeeding practices. Now let's get started. In this session, we will briefly review how breastfeeding can be safely continued in various maternal conditions by focusing on what is recommended, what precautions are needed, and how treatment supports continued feeding. We will be highlighting that most of the conditions, including mental illness, hypothyroidism, diabetes, tuberculosis, hepatitis B, and even HIV with proper antiretroviral therapy, are not contraindications to breastfeeding when managed appropriately. The goal is to guide healthcare providers to offer clear evidence-based advice so that mothers are not asked to stop breastfeeding unnecessarily. Let us begin with maternal mental illness, an important condition that commonly affects women during the postpartum period. When planning medication used during breastfeeding, both clinicians and mothers need to consider the proven benefits of breastfeeding. They must also balance these benefits with the risk of untreated maternal psychiatric illness and the possible effects of medication exposure on the infants. Assessing the safety of psychiatric medications during breastfeeding requires looking at several factors together, like pharmacology, clinical experience, and expert recommendations. So the key considerations include individual risk-benefit assessment because each mother-infant situation is unique and decisions should balance maternal mental health needs with any potential risk to the baby. Continuing pregnancy medications which were safely used during antenatal period are often appropriate to continue during breastfeeding unless specific concerns arise. Select suitable medications with established safety profiles and lower levels of transfer into breast milk. Ongoing monitoring and coordination with regular follow-up and communication with the pediatrician. This helps to ensure infants' well-being while maternal treatment continues. Infant observation when indicated may require tracking the baby for sedation, feeding difficulties, or weight concerns. Using updated references for proper medication choices and safety decisions. Supporting maternal well-being like emotional reassurance, counseling, and practical help should accompany medical guidance to promote successful breastfeeding and mental health. Most psychiatric medications enter breast milk in very small amounts. Among antidepressants, SSRIs such as sertraline, paroxetine, and fluoxetine, along with tricyclic antidepressants, are the best studied and most reassuring. Infant serum levels are usually very low or undetectable, and clinically significant adverse effects are rare. Short-acting benzodiazepines like lorazepam and clonazepam, when used at low doses for short durations, are also generally compatible with breastfeeding, with occasional and uncommon reports of sedation. Similarly, antipsychotics such as haloperidol, olanzapine, and quetiapine have low transfer into breast milk and good safety data. Therapeutic doses of methylphenidate and amphetamines used for ADHD also result in minimal infant exposure. The key message is that in most cases, continuing breastfeeding while treating maternal psychiatric illness is safe and preferable. However, some medications require greater caution rather than automatic avoidance. Lithium is the most important example, as infant serum levels can reach up to 30 to 50% of maternal levels, and its use requires close infant and maternal monitoring. Lamotrigine shows variable infant levels but no serious reported adverse events. Pediatric follow-up is advised. Valproate and carbamazepine should be used cautiously with infant liver function monitoring. Among antipsychotics, risperidone has low milk levels but isolated adverse reports. Aripiprazole can suppress prolactin and is associated with a high risk of lactation failure. Clozapine remains contraindicated due to agranulocytosis during breastfeeding. Non-stimulants like clonidine and guanfacine used for ADHD may reduce milk supply. Infants should be monitored for sedation and feeding issues. Thus, most drugs need monitoring and individualized decision making, not routine cessation of breastfeeding. In summary, most psychotropic medications are compatible with breastfeeding when used judiciously. Use the lowest effective dose. Prefer immediate release formulations. Monitor the infant clinically for feeding, alertness, and growth. The harm from untreated maternal mental illness clearly outweighs the theoretical risk of medication exposure through breast milk. Protecting maternal mental health and supporting breastfeeding should always go hand in hand. In lactation practice, the real risk is often not the medicine, but the untreated illness. The safest approach is not avoidance, but informed, evidence-based use. Our next condition is hypothyroidism, one of the most common endocrine disorders affecting women of reproductive age. Mothers diagnosed with hypothyroidism often wonder whether they can continue breastfeeding or whether their condition or treatment might affect their baby. The reassuring answer is that with appropriate treatment, breastfeeding can continue safely. To understand why, let us briefly review the hormonal changes in hypothyroidism. When circulating thyroid hormones, that is triiodothyronine T3 and thyroxine T4 are low, the hypothalamus responds by increasing the release of thyrotropin releasing hormone called TRH. TRH then stimulates the pituitary gland to secrete thyroid stimulating hormones called TSH as well as prolactin. As a result, in hypothyroidism, we commonly see elevated TSH along with elevated prolactin levels. This is an important concept because although prolactin is essential for lactation, its presence alone does not guarantee adequate milk production. Effective lactation requires appropriate hormonal balance and target hormone responsiveness, which we will discuss in the next slide. Despite elevated prolactin levels, mothers with hypothyroidism may still experience inadequate milk production. This is because adequate levels of thyroid hormones, that is T3 and T4, are essential for the mammary gland to respond effectively to prolactin. Thyroid hormones regulate cellular metabolism and energy availability. In hypothyroidism, overall metabolic activity is reduced, resulting in less energy available for milk synthesis within the mammary epithelial cells. Consequently, the mammary gland response to prolactin is impaired, leading to low milk output despite high circulating prolactin levels. Clinically, this underscores the importance of identifying and correcting hypothyroidism in mothers. presenting with low milk supply. Breastfeeding is safe in mothers with hypothyroidism when the condition is appropriately managed. The standard treatment levothyroxine, which is synthetic thyroxine, is compatible with breastfeeding. Only minimal amounts of transfer to breast milk, and these amounts are not sufficient to cause any adverse effects in the infant. In fact, optimizing the maternal dose of levothyroxine is essential not only for the mother's health but also to support adequate milk production. When thyroid hormone levels are corrected, the mammary gland response improves and lactation outcomes are better. Regular thyroid function testing in the postpartum period is important as thyroid requirements may change after delivery, and timely dose adjustment help maintain both maternal well-being and its effectiveness to breastfeeding. In autoimmune hypothyroidism such as Hashimoto's thyroiditis, thyroid antibodies do not transfer into breast milk. Therefore, breastfeeding remains safe. Moreover, evidence suggests that breastfeeding may even reduce the infant's future risk of developing autoimmune thyroid disease. So, with proper treatment and follow-up, hypothyroidism should not be considered a reason to discourage breastfeeding. Our next condition is maternal diabetes. Diabetes during pregnancy requires careful management because poorly controlled blood glucose levels can lead to complications for both the mother and the baby. Maternal complications include miscarriage and preeclampsia, while neonatal complications may include preterm birth, congenital anomalies, macrosomia, and birth-related complications. Therefore, maintaining good glycemic control throughout pregnancy is essential for optimal maternal and fetal outcomes. But an important question after delivery is, can mothers with diabetes breastfeed? The reassuring answer is yes. In fact, breastfeeding is strongly recommended as it provides important benefits for both the mother and the infant. While diabetes has many implications for maternal health, our discussion here will focus specifically on breastfeeding babies born to mothers with diabetes. Mothers with type 1 diabetes, type 2 diabetes, or gestational diabetes can successfully breastfeed their babies. In fact, breastfeeding is strongly recommended because it provides the ideal nutrition for the infant. Research has shown that breastfed babies are less likely to become overweight and may have a lower risk of developing diabetes later in life. Therefore, maternal diabetes should never be considered a reason to avoid or delay breastfeeding. Breastfeeding is not only beneficial for the baby, it also offers important health advantages for the mother. Lactation helps the body utilize glucose more efficiently and improves insulin sensitivity. Mothers often find it easier to lose the weight gained during pregnancy while breastfeeding. For women who had gestational diabetes, breastfeeding can reduce the risk of developing type 2 diabetes in the future. The protective effect appears to increase with longer durations of breastfeeding. In addition, breastfeeding lowers the risk of certain cancers, including breast and ovarian cancer. Thus, breastfeeding contributes to both immediate and long-term maternal health. Having discussed the benefits of breastfeeding in mothers with diabetes, let us now look at some practical tips to help them breastfeed successfully. Mothers with diabetes should initiate breastfeeding as early as possible, preferably within the first hour after birth. Skin to skin contact and frequent feeding help establish lactation and support the baby's adaptation to life outside the womb. Mothers should monitor their blood glucose levels regularly as breastfeeding can sometimes alter glucose requirements. It is also helpful to keep a healthy snack and plenty of fluids nearby while breastfeeding. Mothers should consult their healthcare provider regarding any necessary adjustments in insulin or other diabetes medications while breastfeeding. Some babies born to diabetic mothers may develop low blood glucose shortly after birth. In such situations, early and frequent breastfeeding, along with skin to skin contact, is often the most effective initial management. So, to conclude, maternal diabetes is not a contraindication to breastfeeding. On the contrary, breastfeeding provides important health benefits for both mother and baby and should be encouraged and supported from birth. Let us now move on to another important maternal condition, that is tuberculosis, one of the common infectious diseases encountered during the reproductive years. A frequent concern is whether a mother with tuberculosis can safely breastfeed her baby or not. However, WHO recommends breastfeeding irrespective of the mother's TB status. Tuberculosis is transmitted mainly through airborne droplets and not through breast milk. The risk of tuberculosis transmission through breast milk is negligible. Although anti-tubercle medicines pass into breast milk in small amounts, there is no evidence that they can harm the infant or cause drug resistance. Therefore, mothers with tuberculosis should be encouraged and supported to breastfeed. The next question is, if breastfeeding continues, how do we protect the baby? The key lies in effective maternal treatment and simple infection control measures. So the best way to protect the baby is to ensure that the mother receives effective treatment and follows simple infection control measures. Because TB spreads through the air, mothers should wear a surgical mask when close to the baby, cover their mouth and nose while coughing or sneezing, wash their hands regularly, and ensure good ventilation. These precautions reduce the risk of airborne transmission while allowing breastfeeding to continue safely. Separation of the mother and baby is generally not necessary. To summarize, when tuberculosis is diagnosed in the mother, our priorities are simple: treat the mother, protect the baby, and continue breastfeeding. This leads to next question. How should an infant born to a mother with tuberculosis be assessed? Early evaluation is important because tuberculosis in newborns often presents with non-specific symptoms. Infants born to mothers with tuberculosis should be assessed carefully. Symptoms of tuberculosis in newborns may include fever, poor feeding, lethargy, poor weight gain, or respiratory problems. If tuberculosis is suspected, evaluation and treatment should begin promptly because the disease can progress rapidly in young infants. Fortunately, many exposed infants remain healthy and can continue breastfeeding while being monitored appropriately. To summarize, every infant born to the mother with tuberculosis should be assessed early and followed up accordingly. Moving on to the key issue. What if an infant requires tuberculosis preventive therapy or treatment? Should breastfeeding be continued? Yes, of course. Even when an infant requires preventive treatment or treatment for tuberculosis, breastfeeding should continue. Infants receiving preventive treatment are often given pyridoxine, that is vitamin B6 supplementation. BCG vaccination may be postponed until preventive treatment is completed. WHO strongly supports keeping mothers and babies together whenever possible because successful breastfeeding is vital for infant survival, growth, and development. The overall message is simple. Tuberculosis is not a contraindication to breastfeeding. With appropriate treatment and infection control measures, mother can safely breastfeed and remain with their babies. Now, before we conclude our discussion on tuberculosis, let us briefly understand tuberculosis preventive treatment or TPT, as it plays a key role in the management of children exposed to tuberculosis. It is important to remember that children under 5 years of age who are household contacts of a person with bacteriologically confirmed pulmonary tuberculosis and who do not have a active tuberculosis disease after appropriate evaluation should receive TPT even when TB infection testing is not available. In simple terms, TPT is given after TB exposure to prevent the child from developing active tuberculosis. Let us now move on to another important maternal infection, that is hepatitis B. A common concern is whether mothers with hepatitis B can safely breastfeed their babies. According to the current evidence, breastfeeding is recommended and should be initiated as early as possible after birth. Although hepatitis B can be transmitted from mother to baby, this transmission occurs mainly during childbirth. Breastfeeding itself does not increase the risk of transmission. Therefore, maternal hepatitis B infection is not a contraindication to breastfeeding, and mothers should be encouraged to breastfeed their infants. Now, the issue arises, if breastfeeding is safe, then what measures are needed to protect the baby? Let's look at the recommended newborn immunoprophylaxis. Infants born to mothers with hepatitis B should receive hepatitis B immune globulin or HBIG along with the first dose of hepatitis B vaccine within 12 hours of birth. This provides immediate as well as long-term protection against infection. The infant should then complete the remaining vaccine doses according to the recommended schedule. Breastfeeding should continue throughout. The key message is that timely immunization allows safe breastfeeding while effectively protecting the infant from hepatitis B infection. Let us now look briefly at hepatitis C. Similar to hepatitis B, mothers with hepatitis C can breastfeed their infants. Current evidence shows that there is no documented transmission of hepatitis C through breast milk. Therefore, breastfeeding is recommended and should be encouraged. Unlike hepatitis B, there is currently no vaccine available for hepatitis C. The key message is simple. Hepatitis C is not a contraindication to breastfeeding. However, cracked or bleeding nipples require special consideration, which we will discuss in the next slide. Having established that mothers with hepatitis B and hepatitis C can usually continue breastfeeding, let us now discuss one situation in which direct breastfeeding may need to be temporarily interrupted. This applies when the nipples are cracked or bleeding. In this situation, blood exposure may increase the risk of viral transmission. Therefore, breastfeeding should be temporarily stopped from the affected breast. To maintain milk production, the mother should express and discard the milk until the nipple has healed. Once healing occurs, breastfeeding can be resumed. You should remember that this is a temporary interruption, not a permanent cessation of breastfeeding. We will now move on to a very important topic, breastfeeding in mothers living with HIV. Before we begin, I would like to make an important disclosure. The information presented in this section is based on the current WHO recommendations on HIV and infant feeding. The WHO recommends lifelong antiretroviral therapy called ART for all mothers living with HIV. In countries that have adopted this policy, mothers on ART are encouraged to breastfeed according to the recommended infant feeding practices. However, national guidelines may differ depending on the local policies and healthcare resources. Therefore, mothers should always follow the advice of their healthcare provider and the recommendations of their national HIV program. The purpose of this discussion is to understand the WHO recommendations while recognizing that clinical decision should always follow national guidelines. The next important question is, can a mother living with HIV safely breastfeed her baby? The answer lies in balancing two important goals, protecting the infant from HIV infection while also ensuring that the infant survives and thrives. Breastfeeding reduces the risk of diarrhea and pneumonia, malnutrition, and other childhood illnesses, thereby improving survival. Although replacement feeding eliminates the risk of HIV transmission through breast milk, it may increase the risk of illness and death in many settings. With lifelong maternal antiretroviral therapy and good adherence, the risk of HIV transmission during breastfeeding is greatly reduced. Therefore, the WHO recommendations aim to maximize infant survival while minimizing HIV transmission. To better understand the WHO recommendations, it is important to appreciate the balance between the risk of HIV transmission and the benefits of breastfeeding. Without antiretroviral therapy, about one-third of infants born to the mothers living with HIV may acquire the infection through pregnancy, childbirth, or breastfeeding. While lifelong maternal ART and good adherence, the overall risk of mother-to-child transmission across pregnancy, delivery, and breastfeeding falls dramatically to about 3 to 5%, meaning that a vast majority of HIV-exposed infants remain HIV-free. If we look specifically at transmission through breastfeeding, when the mother is receiving 3-drug ART, the risk is 2% compared with about 1% when breastfeeding is not practiced. The key message is that effective ART substantially reduces the risk of HIV transmission to very low levels, including during breastfeeding. In addition, antiretroviral prophylaxis given to the infants for the first 4 to 6 weeks after birth provides further protection by reducing the risk of mother-to-child transmission. However, evidence shows that the infants who are not breastfed face a much greater risk of dying from common childhood illnesses such as diarrhea, pneumonia, and malnutrition. Therefore, WHO recommendations are based on achieving the best overall outcome, minimizing HIV transmission while maximizing infant survival. Having understood why WHO recommends breastfeeding, the next question is how mothers living with HIV should feed their infants. WHO recommends exclusive breastfeeding for the first 6 months while the mother continues lifelong antiretroviral therapy. Complementary foods should then be introduced with the breastfeeding continuing up to 24 months or beyond. If exclusive breastfeeding is not possible, mixed feeding is still preferable to not breastfeeding at all. Likewise, even if breastfeeding cannot continue for the recommended duration, a shorter period of breastfeeding is still better than never breastfeeding. The key message is very simple. Every breastfeed provides important benefits. Before we conclude our discussion on HIV and breastfeeding, let us look at the key factors that make breastfeeding successful. Because success depends upon much more than medications alone. Mothers need lifelong adherence to antiretroviral therapy, regular follow-up, and skilled breastfeeding counseling. They also need support from their families, workplaces, communities, and healthcare providers. When treatment, adherence, and support come together, mothers living with HIV can breastfeed confidently and safely in accordance with the WHO recommendations. Having discussed breastfeeding in mothers living with HIV, let us now move to another important maternal infection, that is chickenpox or varicella. Mothers often worry that they should stop breastfeeding if they have developed chickenpox. Let us see what the current evidence tells us. According to the Centers for Disease Control and Prevention, chickenpox is not transmitted through breast milk. The virus spreads mainly through respiratory droplets and direct contact with the fluid from the skin blisters. Therefore, mothers can usually continue breastfeeding while following good infection control practices, including frequent hand washing and keeping skin lesions covered. The key issue is whether there are any situations in which direct breastfeeding needs to be interrupted. The answer is yes, but only in specific situations. If the mother's chickenpox lesions are away from the breast, breastfeeding can continue safely. However, if blisters are present on the nipple or areola, the infant should not feed directly from the affected breast because of the risk of contact with infectious fluid. During this period, the mother should express milk regularly to maintain her milk supply and resume direct breastfeeding once all the lesions have dried and crusted over. If chickenpox develops shortly before or after delivery, both mother and baby should receive prompt medical evaluation because newborns may require additional monitoring or preventive treatment. Let us now turn to another viral infection that commonly raises questions about breastfeeding, that is herpes simplex infection. The good news is that herpes simplex virus is not transmitted through breast milk and the mother can continue breastfeeding. The risk to the baby comes from direct contact with active herpes lesions. Therefore, mothers with herpes simplex can usually continue breastfeeding while taking appropriate precautions, including good hand hygiene and preventing direct contact between the infant and any active lesions. The key message is simple. Herpes simplex is not a contraindication to breastfeeding. This leads us to consider whether there are any situations in which direct breastfeeding should be interrupted when mother is suffering from herpes simplex. If there are no lesions on the breast, mother should continue breastfeeding normally. However, if an active lesion is present on the nipple or areola, the infant should not feed directly from the affected breast until it has completely healed. Breastfeeding can continue from the unaffected breast provided it is free of lesions and resume from the affected breast once all the lesions have healed. Mothers should also keep all herpes lesions covered whenever possible and wash their hands thoroughly before handling the baby. These simple precautions greatly reduce the risk of transmission while preserving the many benefits of breastfeeding. Remember, it is the active lesion that poses a risk, not breast milk or breastfeeding itself. This concludes session 13, Breastfeeding Approach in Special Situations. In session 14, Breastfeeding, Shaping the Infant Microbiome, we will discover how breastfeeding helps shape the infant microbiome and lays the foundation for lifelong health. We encourage you to continue sharing your thoughts, questions, and suggestions for future topics to help us better support your learning journey. Feel free to reach out via email at rajinder_gulati at hotmail.com. Your feedback is invaluable as we strive to create informative, helpful content. Thank you for joining us, and we look forward to continuing this journey together. Have a wonderful day.